good morning, everyone. Thank you for joining us today, and so excited that you made it to your first session. Welcome, especially if you're new, and if this is your second time, third time, 10th time being here, welcome back. We're excited to have you. And today's presentation is Integrating Dental Care into Primary Care, so we're very excited that you're here.
As you may know, this session qualifies for CME and Dental CE. So once it's done, please pick up your paperwork at the registration desk. And so without further ado, I would like to announce our speakers today, and they are Joseph Jefferson, you can clap, and then we have Andrew Kawasaki and Nilu Sherpa. So enjoy.
Once again, welcome. Good morning. I'd like to start with prayer. I'm so excited about the vision of this conference and that we are all together here to serve the Lord through healthcare. So, dear Heavenly Father, we come before you thanking you for another morning, thanking you for this great privilege to work with you and what you want to do amongst our communities, Lord. And we just pray that by your Holy Spirit, that you would empower us, give us wisdom, give us compassionate hearts, to share the gospel of Jesus Christ and provide high-quality health care. For your name's sake, for the expansion of your kingdom, we pray. Amen. Okay, so my name is Joseph Jefferson. I am a staff dentist with Christ Community Health Services in Memphis, Tennessee, and also faculty through the CMDA Residency Plus program. If you came here specifically to see Dr. Musser, Katie Musser, unfortunately she's not here. I'm taking her place. So if you don't see her, that's why she's not here. But if you had a message for her, anything like that, just let us know and we can convey it to her.
Hi, my name is Nilu Sherpa. I am a first-year AAGD resident with NYU Langone. I'm also working in Christ Community and part of the CMDA Plus program. I am originally born and raised in Nepal and living in New York for most of my life and recently moved to Memphis.
And hello, I'm Dr. Andrew Kawasaki. I am in my third year of the Dental Plus residency, and excited to be here.
Your voice is
Disappeared. Okay, I can take off my mask. Sorry, just a slight sickness. Dr. Andrew Kawasaki, third year in the Dental Plus residency, and happy to be here talking to you.
I know it looks like we have this large team, but don't worry, we're not going to provide too much overwhelming information. So basically, we want to just give you a general idea as you see your patients. I know that a lot of you could be PCPs, not many dentists in here, but just so that you would have just a general understanding of what does a healthy mouth look like, some tools to assist you in tackling oral health with some of your patients. We want to debunk some of the dental myths that they may have and, provide a little bit of common language between us dentists and you, PCP and the PCP. So I'm going to show a few slides of what a healthy mouth looks like and then a few slides of what some disease can look like. Go for it. So the upper left, we have a nice healthy smile, very white teeth. Doesn't have to be white, but just as long as there's not many, any dark spots or holes in the teeth. Then you have the gingiva is tightly attached to the teeth and the periodontium. And then on the upper right, that the circle is the tonsils. And what could be significant is maybe if you see something white stuck in the tonsils, and we call those tonsil stones. And usually what it is plaque or some type of debris has been caught in the pits in the tonsil, and it becomes a stone. And either you can help remove it, or sometimes you can use some type of gargle, or you can just refer them to the dentist, and we can take care of that. Then lower left is dorsal tongue, lower right, lateral side of tongue, and that'll become a little bit more important as we go further in the presentation. Upper left, floor of mouth. And what is circled is a bump, and actually that's a torus, and it's a pretty much a normal part of anatomy, but some patients, they may have had it all their life, and then one day they look in the mirror, a certain angle, and like, oh, what's that? Where did that come from? It must be a new growth, and they come to you and very concerned, and you may look in, and if you don't know about tori, then you may be as concerned as well, but actually this is normal part of anatomy, and no need for treatment, totally benign. It's just a growth of bone. Sublingual is upper right, and just what could be concerned is they lift their tongue up, and you see blue, black, sublingual veins. No great concern, only if it's possibly ballooned or if there's some type of irritation or pain. And then the lower pictures are just what a normal cheek looks like, and that'll be more important as we go into more of the presentation as well. Okay, this is more pictures of those tori or exostoses. It's just a bony growth of the upper and lower jaw. But if you're not aware of it, it does look concerning. I know if I would have woke up and had no idea and I saw that the roof of my mouth, I'll be quite concerned. I'll go straight to my doctor. But basically, this picture on the left side is a palatal torus. It's just growing in midline of the roof of the mouth. And on the right side are two very large mandibular tori, and totally benign, no need for treatment. The only reason you would consider or recommend treatment is if the patient didn't have any teeth and they needed a denture made, because the tori could prevent fabrication of a good denture. So you would have those removed before the denture is fabricated. Okay, now talking about caries, aka cavities. Like I said, very obvious, usually a dark spot, a hole in the tooth, but sometimes not as obvious. On the lower slide, it just looks like stains in the pit and the fissures, but actually that is decay. Next is periodontal disease. It is disease, inflammation of the periodontium, including the gums, the bone around the teeth. It's a support for the teeth. In that upper left picture, you see swollen gums. They would bleed very easily. You probably have a bad smell. There's usually a collection of plaque, tartar that's been attached to the teeth or under the gums for a very long period of time. It's causing destruction of the bone and the gingiva around the teeth. On the lower slides, you see a bit of an advanced stage, and so the bone and the gingiva have receded from the teeth so much that they begin to shift or become loose. And, I had quite a few patients just, they say, well, one day I woke up and my tooth was gone. Go ahead, you can ask a question.
What exactly are you seeing in that top left?
So I'm looking right here at the gingiva. So if you compare the left and the right pictures, the gingiva on the left is quite swollen in between the teeth, whereas on the right is not as swollen. Can you appreciate that? Yeah, and usually if you touch the gingiva, it'll bleed quite easily, and even the patient will probably complain, hey, my teeth are, and my gingiva, my gums are bleeding very easily. Every time I brush my teeth, they bleed. So that's usually, I know that they have either just gum, they have gum disease. And usually you'll smell a bad, have halitosis. Okay, in concerns for oral cancer, there's three things we want you to remember. The most common sites are the lateral border of tongue, the floor of the mouth, and the buccal mucosa, or on the cheek area. And so that's why we were kind of giving you an idea what does healthy look like, so that you would know what unhealthy looks like. And so, as you all know, if there's been a growth that's getting larger, or if there's been an ulcer that doesn't seem to go away, these are causes for concern. Then we have leukoplakia, erythroplakia. Not very common lesions, but the fact that sometimes they are precancerous, we just wanted to make you guys aware. So basically, it's a white patch, and you can't remove it. It's not painful. It could be slightly raised, especially with leukoplakia. And with both of them, something is irritating the oral cavity. It could be smoking, it could be alcohol consumption, it could be an ill-fitting denture, it could be a rough area on the tooth. Something is chronically irritating the inside of the mouth, causing these patches. And usually if you find one, To know if it's precancerous, of course, you have to take a biopsy. Okay. I know I'm moving around quite quickly. A lot of information to cover, but want to also give you guys some resources to help you tackle oral health with your patients. So, in a very basic form, the formula for decay is sugar, bacteria, plus acid equals tooth decay. And so in educating our patients, we want to reduce the variables in this formula. So we want to reduce sugar intake, we want to reduce the bacterial load, we want to reduce acid. And for the bacterial load, basically we have a mechanical mechanism to remove the bacterial load, and that's just simply brushing your teeth and flossing. It's just simply removing the bacteria from the teeth. Of course, fluoride has a long history in dentistry, and what we explain to the patients is basically a vitamin for your tooth. It makes the enamel much stronger and less susceptible to dental decay. And Dr. Musser, she made these coloring sheets for our pediatric patients, but she found out that it was very educational for their parents as well. So we pass these out at our clinics, but we also want to make them available to you, and we have some links. We have it linked to these sheets in the presentation that will be provided through the app. Also, some hygiene videos, how to brush properly, how to use floss properly through the ADA website, and some recommendations for using fluoride. Okay, now we want to talk about some of the common myths that our patients come with, and I'm sure they may share the same thing with you. One of our common myths is, hey, I drink Sprite, it's better than Coke. So is that true? Why isn't it true? We want to get some little bit of interaction with you guys. What would you tell a patient? Say, hey, I drink Sprite, I'm okay. I don't drink Coke. So what would you tell that patient? Anybody?
Sugar is sugar.
There we go. Sugar is sugar. Acid is acid. And it would be a great point to just dive into educating them about this formula and of dental decay and how we tackle that. We'll have some more.
Another thing that we frequently hear is, these are just my kids' baby teeth. Why do I even need to worry about them? Just pull them out. Does anyone have thoughts about what you could say to that? Well, yeah, one of the main things is we do want to keep those baby teeth in the mouth as long as we can and let them come out naturally. If they come out too soon, then that's when we see a lot of crowding of the teeth and increased chance of problems with their baby teeth, and also a tooth decay can lead to an abscess, and that can become pretty severe. So those are a few things. Then I also have a lot of patients come in with a lot of tooth problems, and they're like, do I just need to use a harder toothbrush? And do you guys think that's a good? I see a lot of shaking of heads. Yeah. We always recommend just using a soft toothbrush. The harder toothbrushes can really irritate the gums and in some cases lead to abrasion of the teeth. We see little wedges missing from the sides of the teeth. That could be a result of that.
I get this one a lot. Just pull out my teeth, I'll replace it with the denture, and that will be better. What do we think about that? No. Yes. Good answer. Actually, a lot of my patients, I say this, especially in a health clinic, they just want to, the first thing they want to do is like just extract my teeth, take it out. I always like to tell them, hey, I can take your teeth out, but you're going to lose 90% of your function. And people with dentures, it's only like 10% of function compared to your real teeth. So then I kind of like add a little bit, well, this is what God made, and this is what I'm going to make for you, but what God made is much better. And that kind of helps a little bit. All right. Okay, there you go. How many PCPs in the room? Okay, students, dentists, hygienists, okay, assistants. All right, I just wanna gauge. All right, what I'm gonna tackle prophylactic antibiotic guidelines, the most updated prophylactic antibiotic guidelines, and dental treatment and cancer history. I'm sure you guys know a lot more about it than I do, but this is what I've gotten out of the research that I did. So it's just to provide a common language between the dentist and the provider, because we get a lot of confusion about it, especially even in our health clinics. So let's go with the first slide. Okay, so recommendation for antibiotic prophylaxis prior to anything, and historically, there's only been 2 reasons why we give antibiotic prophylaxis. Number 1 is that individual with heart condition that increase the risk of infective endocarditis, and the second would be patient with prosthetic joints who may be susceptible to hematogenous infections at the prosthetic site. So, since those are the 2 main reasons, in 2007, there was a paper came out by AHA, American Heart Association, and they basically have suggested only 4 cardiac conditions where antibiotic prophylaxis is recommended, and these 4 are patient with prosthetic cardiac valves or prosthetic material, if anyone has had a history of infective endocarditis, patient with congenital heart disease, specifically cyanotic, and 4th condition is cardiac transplant recipients who develop cardiac valvulopathy. Other than these 4, there's no other recommendation for infective endocarditis for antibiotic prophylaxis. So, and even among these 4, specifically when it comes to dental procedures, only dental procedures that involve manipulation of gingival tissues or periapical region of the tooth or perforation of the mucosa. In cases where we're doing a denture or where we're doing orthodontics or we're doing placement of brackets, shedding of primary teeth, antibiotic prophylaxis is not recommended in these circumstances. Any questions? Yes. Not quite so close. Okay, thank you so much for that suggestion. Is this better? Good? Yeah? Okay, thank you. Okay. All right, just raise your hand. Yes. Flip back this one. I will, if anyone, I haven't linked the papers, but if you guys want the papers where I got these from, I can send that to you in the end. You can just come talk to me. And they have it all laid out. Alrighty. So this is for dental procedures. All right. Some of the significant findings that came out of this study was that it's much more likely for someone to develop transient bacteremia, develop infective endocarditis due to transient bacteremia from routine dental activities, like brushing your teeth, chewing food, rather than a dental procedure. Another thing is an exceedingly small number of cases with infective endocarditis can be prevented by antibiotic prophylaxis. What's right before that, I'm just going to talk about this really quick. And there's a very small number of cases where there was any form of, there was any form of infective endocarditis suggested to be treated, even with people that took antibiotic prophylaxis that worked 100%. One of the main things is shared decision making. A lot of the times you can talk to the patients and say, you don't need antibiotic prophylaxis, and they're like, I need it. So maybe we can go back to this paper and talk about, hey, this is what the latest recommendations are. Look at these 4 guidelines. These are the only guidelines where you need antibiotic prophylaxis. So never for cleaning. So if you go back to this slide, in these 4 conditions, if patients come with these 4 conditions, they're also depending on what kind of cleaning. So there's some things, sometimes we do a prophylaxis, which is not a deep cleaning. Sometimes we do an SRP for some patients, so it depends on what kind of cleaning, but only recommended when patients come with these 4 conditions. Okay, all right, that was infective endocarditis. Now, prophylactic antibiotics prior to dental procedures in patient with prosthetic joints. The recent recommendation is prophylactic antibiotics not indicated again. So prophylactic antibiotics not indicated anymore after the 2007 study. Now there are cases when people have prosthetic joints that have infection, that reoccurrence of infection. In those cases, the orthopedic surgeon, we recommend that the orthopedic surgeon provide the antibiotic prophylaxis because they know more about the patient's condition than a dentist would. So if a patient comes in and says, I have a prosthetic joint, do I need antibiotic prophylaxis? My answer is no, but go talk to your orthopedic surgeon. Have you had the surgery multiple times? Has there been signs of infection? And that's something better for them to determine than for a dentist. So I'm like, let's go back and talk to them. All right. And in the cases that we do antibiotic prophylaxis, these are our recommendation. The only one that's taken out of here since the 2007 study is clindamycin. Okay. Yeah, and these are the papers that I got it of. I got it, most of my resources from that 2007 paper. Thank you. And yeah, that was the main one, but I can give both of these to you. Okay, so my second topic is dental treatment consideration for cancer patient. Now, pre-treatment, I just want to talk about pre-treatment consideration during active therapy, and following completion of cancer treatment. The goal of oral and dental care are different during the procedures, before the procedure, and after the procedure. Okay, so pre-treatment consideration. Jane Doe walks into your clinic. She was recently diagnosed with breast cancer, stage 2. We're going to start treatment. Where does a dentist come in between all of this? That's what we're going to talk about. You look inside Jane's mouth, and it doesn't look like what Dr. Jefferson showed you, like a healthy mouth. This is what her mouth looks like. Now, do we want to start chemo right away, or do we want to kind of involve dentists in this? And why do we want to involve dentists in this? And that's pretty much what I'm going to be talking about. Very broad strokes here. If you guys want more details, I will link those papers, okay? All right. So why consider Jane's mouth at all? Oh, yeah. So first case, oral mucositis. I'm sure you guys know of oral mucositis, seen oral mucositis in your cancer patient. My mom, when she had chemotherapy, she had oral mucositis, and I was very young at that time, so we didn't know what was going on. It was a little scary to see that. Painful, not able to eat, not able to swallow, and she had no idea why that was happening. So that's one of the reasons we want to consider Jane's mouth. Xerostomia, dry mouth. Our saliva are basically God's gift to us to cleanse our teeth. When we have xerostomia, you think it can lead to dental caries, right? So that's another reason we want to consider. Multiple reasons we want to consider. I just want to talk about the top 3 most common one that we hear about. Okay. Yeah, so then I wrote down some of the other consideration: opportunistic infection like viral or fungal, salivary gland dysfunction, taste disturbances, pain, dehydration, and nutritional compromise. Okay, what does the National Cancer Institution say? They recommend that dental professionals be considered a part of your cancer care team, and that we send the patients 4 weeks prior to initiating any cancer treatment. And that's if they come to us 4 weeks prior and they need an extraction, they need any healing, so that those infections are not going to affect your treatment. Okay, so you did your thing 4 weeks prior to your patient's appointment. You send them to the dentist. What do we do? So we're going to perform a thorough oral exam. We're going to institute optimal oral hygiene. We're going to instruct them on optimal oral hygiene. We are going to eliminate any source of infection. So like Dr. Jefferson was talking about, someone with periodontal disease. Sometimes the periodontal disease is so aggressive that, let's say they come with swelling, they come with infections in their mouth. We want to take care of that. We want to get rid of that before we start any treatment. Okay, and yeah, like I said, extract any non-restorable teeth. Oh, we have a question. Yes. Prior to any cancer therapy. Yeah, and now there are exceptions where if someone is diagnosed with cancer and the treatment has to start right away. There's always that exception. This is if your patient is going to start treatment 2-3 months down the line. These are some things to consider. Okay. One of the things we like to tell our patient is we like to administer fluoride, and these are fluoride trays. What we do is we make these trays for patient, and they can actually do them at home because they don't have to keep coming back to us all the time. And like we talked about, fluoride, good vitamins, they make your teeth stronger. This is something we like to. They can do it like 1 hour a day. Pop these fluoride trays on, yeah, and educate the patient. That's probably one of the most important things. Now, during active therapy, I just kind of want to focus on oral mucositis. So Jane Doe comes into your clinic. She is now in my clinic, and she is going to start her chemotherapy or her radiation, or I should say cancer therapy. So what am I telling Jane? I'm telling her, hey, brush well, floss well, and I'm gonna teach her how to floss, because sometimes if you don't know how to floss, you can really aggravate the gingival tissues, right? So we're gonna teach her proper flossing techniques. Now, if she comes in and I'm gonna start educating her about oral mucositis, one of the a couple of things that you can also recommend your patient for oral mucositis, and I'm sure you guys already know, but if not, these are some of the ways we can recommend them. At-home treatments is what I'm talking about. Okay, 1 teaspoon of table salt in 1 quart of water to make normal saline. And what they're gonna do is like swish and like spit. That's basically the treatment for this, and just as necessary to maintain oral comfort. Next, baking soda. I don't know if you guys have heard of this, but baking soda, we adding 1 to 2 tablespoons per quart of water if viscous saliva is present. And this is also to eliminate any pain associated with oral mucositis. Now, if your patients are, yes. So, oh no, sorry. So this is a separate ingredient and this is a separate ingredient, yeah. But they can both be used simultaneously. Okay. If your patients come in with dentures, something they have to remove out of their mouth, making sure the dentures are kept clean. How are they kept? If you can do a 1 to 10 dilution of bleach and leave it overnight. Ask them to mechanically brush those plaques off of the denture. Those are all things that can really help, because sometimes if you leave them on, like we talked about, I don't have pictures of it, but oral candidiasis. A dirty denture leads to oral candidiasis, and this is something we teach our patients even when we deliver the dentures to them. Okay. Oh, a prescription you guys can write for your patient: chlorhexidine, 0.12%, 15 milliliter as mouthwash. Swish it for 30 seconds twice a day. Now, this oral chlorhexidine is known to help prevent buildup of bacteria, and it also, like, for up to 12 hours, and it provides a protective layer over your gums and your teeth. Okay, so following treatment, main thing following treatment is maintaining that visit. Every 4 to 6 months, we want to be able to see our patients. We want to be able to see if there's, like Dr. Jefferson talked about, we want to be able to look at those sites of your mouth that had a very high incidence of cancer. We want to be able to maintain. Sometimes after patients come from like a cancer therapy, they've gone through a lot with their oral, so we want to be able to see them often. We want to be able to educate them often, and we want to be able to provide any necessary treatments often. I think that's honestly the three main things. These are the references that I used, but yeah, any questions?
Okay. So I am now going to talk about antithrombotic agents and dental treatment. This comes up often. Some places I've been to, I walk into a room and my dental assistant tells me we can't do anything today because they're on a blood thinner. I'm like, well, let's wait and see. And sometimes a patient will tell me I can't do anything. So, we can talk to the PCP. Sometimes it's really quick. Sometimes it takes a long time. So I just wanted to talk about this so that we all can know how to communicate and kind of when it's necessary to stop some antithrombotics or if it is. So as you know, with antithrombotics, whether it's warfarin or Eliquis, whatever it be, patients are on those to prevent the things on the left, stroke, myocardial infarction, and dentists or surgeons are often concerned about the things on the right, prolonged bleeding, bruising, and honestly, a lot of dentists are just like, I don't really know what to do, so I'm just going to refer this patient or see someone else. And so it is a balancing act, and to help us kind of work through that balancing act, we need to look at really the risk of bleeding with a procedure and the thromboembolism risk. So in terms of risk of bleeding with a dental procedure, here is something from an article by Wojcik, where they stratify it, I think using, I can't remember the system that they used, my apologies, but They put out the bleeding risk into these categories, and in most situations for a general dentist, I'll be taking out 1 to 3 teeth. If someone needs multiple teeth out, then I probably would just have them come in multiple times. So I'm just taking out 1 to 3 teeth. And then the risk of bleeding really is low. Something for a deep cleaning, the risk is kind of moderate, or if there is an impacted tooth that needs to come out and need to cut away some bone or move the gums out of the way to get that out, that would be a moderate risk. The only real things that would be high risk are the more complex gum surgeries or oral surgeries that a specialist would be doing for the most part. In terms of thromboembolism risk, here are the conditions that are high risk. So prosthetic heart valves, if they've had a thromboembolism while on anticoagulants in the past. And you can read through these. If they're these and we're doing something a higher or moderate risk procedure, then we would consider an interruption of their anticoagulant therapy based off of the recommendations of their cardiologist or the PCP. Anything that wasn't on that previous slide is really a low thromboembolism risk. So for those simple extractions, things that were a low bleeding risk and fall into this low thromboembolism risk, then there's no need to discontinue any of the anticoagulants, and you can just kind of continue with treatment. We have different things we can use at the time of pulling out a tooth to help manage the bleeding in that time. And yeah, if they're moderate risk procedures, then maybe we would kind of talk to the cardiologist and figure out if we need to discontinue. The last point on here is bridging not recommended. So if it is a high bleeding risk procedure, and they're high thrombo, in the previous slide, if they're the high thromboembolism risk, then there's bridging that can be done where they stop the warfarin and take a low molecular weight heparin. And there's a lot of different thoughts about how to do that. And here is from that paper, and on the slides that we have on the app, you should be able to see a lot of tables like this from that paper as a resource for you. So this just talks about, can you see the cursor? No. If they're taking aspirin and a P2Y12 receptor blocker and low risk or moderate risk, you really don't modify treatment. If it's a high risk, then you can do what's at the bottom of like discontinuing 5 days before and then starting 24 hours later. Quickly talk about some things to think about with pregnant patients. So during pregnancy, in the first trimester especially, we're concerned about things like spontaneous abortion or teratogenesis. And throughout the pregnancy, concern for the mother and just her well-being with the immune suppression that happens, nausea, and increased appetite and cravings. And I'll talk a little bit more about that later. In terms of dental treatment, it is totally safe and necessary to complete dental treatment during pregnancy. Some surveys have shown that 50% of pregnant patients would say they haven't seen a dentist within the last year. So for all of us, it's just helpful if we see a pregnant patient, ask if they've seen a dentist, and kind of encourage that. And then during dental treatment, here's a chart of what we can do during each trimester. Really during that first trimester, because of the risks of damaging the fetus, we do try to focus more on urgent care and wait until second and third trimester for more routine dental care. Here's a picture of my wife. who we have back there, and my son who was in her at this point. So I just put this picture up here, bring up another point. When it comes to a dental treatment that could take anywhere from 15 minutes to 2 hours if it's a root canal that's not going great, what's something we think we would want to be concerned about, or just thinking of being in a dental chair for that long? I think I heard some people saying it, the supine hypertensive syndrome, and just positioning. So if you hear something from a dentist asking what they can do on a pregnant patient, could be helpful just to remind them of this, and that if the patient is feeling lightheaded or anything, or it is a long treatment, when they're farther along in their pregnancy, to have that patient turn over onto their left side to avoid compressing the inferior vena cava. And here's some common things to see. So what you see on the screen in that picture is a pyogenic granuloma. Not too uncommon in pregnant patients, and it's just a inflammation related to irritation on the gums. Most of the time, when they're done with their pregnancy and postpartum, that will go away. Sometimes it does need to be removed either by laser or surgical, and we can take care of that. Not too uncommon to also have some pregnancy gingivitis. We showed pictures of gingivitis earlier. Really just with the little bit of immune suppression, those gums can become a little more irritated and a little more red. And with good oral hygiene and dental care, we can manage that. I've had lots of patients come in and they have a lot of cavities that they blame their pregnancy, saying that the pregnancy took away from the teeth. And that just is another myth we should have had earlier, because the teeth are very stable crystalline form. So the main reason that people could get more cavities during pregnancy is from increased appetite and taking in more of those sugars. And what I always tell my patients when it comes to cavities and sugar is it's not so much the amount, but it's the frequency. And so if you can recommend trying to decrease the frequency, I think the number I was given in school was 5 to 6 times or less is ideal. So I just always say have sugary things with meals and then maybe 1 or 2 other times, which during pregnancy is hard. Yes. In a day, number of times during the day, which I know I'm not the best at some days too, but kind of try to space out that sugar intake and having water throughout the day. And another thing that we can see is some erosion. If they do have a lot of nausea and vomiting, that can wear away at the teeth from those stomach acids. And the main recommendation, if they can handle it, is having some baking soda in water that they swish around after they vomit to help neutralize some of those acids. Also, not too uncommon to see some tooth mobility during pregnancy. Most of the time, that does resolve after pregnancy.
As we were talking about the topic, I was just in my mind, I was like, politics, guys, politics, clinic politics, and just having the conversations and even having the confrontations that need to be taken. And and that's a battle for us, because we're like, okay, we have a pregnant patient come in and we're ready to anesthetize and begin to treat, and then someone comes into the operatory and it's like, hey, what are you doing? And so, we need a clearance, and so, we're on the other side of that, and we have to speak up, and we have to take the time to establish good clinical practice, and also get everyone on board, including the administration, because a lot of us, we're not in private practice. We're working for FQHC or a faith-based organization, and so we need to be knowledgeable about this and sit down with our administrators and get the right policy in place.
No, thank you so much for being here, guys.